Every 12 months, 17.3 million people die from cardiovascular disease.
Yeah.
Just let that number sit for a second. To put that into perspective, that is roughly the entire population of the Netherlands.
Wow.
Just wiped off the map every single year. Yet, we really don't treat it like a global pandemic.
No, we don't.
If a novel virus took out 17 million people this year, the entire planet would grind to a halt. The alarm bells would be deafening.
Oh, absolutely. I mean, it would be the only thing on the news. The borders would close immediately.
Exactly. Because when an infectious disease breaks out, that is a sudden fire burning down the house, right?
Right.
The smoke is visible, the damage is immediate, and the panic is entirely justified. But cardiovascular disease, CVD, it doesn't work like a fire.
No, it's much slower.
It works like termites in the walls. Or, like water, slowly, imperceptibly eroding a concrete foundation. It is built quietly, in the dark, over decades, through these incredibly intricate patterns of behavior, biology, and, as we're going to see today, deep structural inequality. You never see the termites. You just wake up one Tuesday and the structural beam snaps.
Which makes it the silent architecture of risk.
Yeah.
It is the absolute definition of diagnostic muddy waters. I mean, if you break your arm, the X-ray shows a jagged white line, right?
That's obvious.
The doctor points to it and says, there's the problem. But with the cardiovascular system, you are looking at an ongoing dynamic process of decay and repair.
So true.
So for anyone listening to this, whether you're a medical student stepping onto the ward for your first clinical rotation, a public health trainee looking at population data, or, a practicing clinician staring at a patient's chart, you are fundamentally looking at an architectural blueprint.
And that is exactly what we are doing today. We are serving up a companion deep dive to Chapter 8.1 of the Oxford Textbook of Global Public Health.
A fantastic chapter.
It really is. But hear me clearly. Our mission right now is not to just read you a list of textbook facts or recite incidence rates. You can read the chapter for that.
Exactly.
Our goal today is to build clear, actionable, conceptual frameworks. We want to trace the pathway from the underlying risk to the exposure, to the clinical outcome, to the intervention, and finally, to the system impact.
Right.
We want to strengthen your clinical reasoning and your systems thinking.
And to do that, we're going to walk through these blueprints from the macro to the micro and then back out again.
Sounds like a plan.
We'll start with the global map, the epidemiological transition of where these buildings are collapsing worldwide. Then we'll zoom into the physiological fault lines, the metabolic fuel, and the physical pressure in the pipes.
The internal stuff.
Exactly. From there, we'll get into how we actually measure this unseen damage. And finally, we'll look at upstream engineering, like how do we design environments where the foundation doesn't rot in the first place?
Okay, let's unpack this macro map, because you cannot understand the risk of the patient sitting in front of you in the clinic without understanding the global context they live in.
Right.
I gave that staggering number up at top 17.3 million deaths annually, primarily from ischemic heart disease and the cerebrovascular disease, which are strokes.
Yeah.
And the source material projects that will hit 23.6 million by 2030. It is the reigning champion of non-communicable diseases.
By far.
But the thing that completely shatters our historical assumptions is where this is happening.
Right. 80% of those deaths now occur in low and middle income countries, the LMICs.
And this is where I have to pause, because historically, certainly for most of the 20th century, we viewed heart disease as a disease of affluence.
Right. The rich man's disease.
The stereotype was the rich Western executive. Right. The guy with the sedentary office job, eating rich marbled steaks, smoking cigars, who suddenly clutches his chest and has a heart attack at his mahogany desk.
Yeah, the classic trope.
So why has the epicenter of this disease shifted so drastically away from the affluent West to the developing world?
Well, it's a profound shift, and it's driven by what public health professionals call the epidemiological transition.
Okay.
Think about what happens as a country develops economically. For centuries, the main killers in a developing nation are communicable diseases, malaria, tuberculosis, cholera.
Infections.
But as sanitation improves, as antibiotics are introduced, people stop dying of infectious diseases in their 20s. They live long enough to develop chronic cumulative diseases.
So they live long enough to let the termites do their work.
Exactly.
But wait, if they are just following the path of the West, Why are they dying at such disproportionate rates? I mean, in the U.S., our smoking rates are down. We have statins. We have advanced surgical techniques. Aren't we winning the war on heart disease in the West?
You would think so if you only looked at mortality.
Yep.
In the United States and Western Europe, our absolute mortality rates from CVD have dropped substantially over the past 3 decades. But here is the terrifying twist the data shows us.
Lay it on me.
While mortality is down, prevalence and hospitalizations are skyrocketing. Heart failure hospitalizations, for example, more than doubled between 1980 and 2010. They hit over 1 million in 2010 alone.
Wait, let me make sure I'm understanding this. We aren't actually preventing the disease from happening.
Yeah.
We are just stopping people from dying in the first 20 minutes of the heart attack.
Precisely. We have engineered a massive, highly expensive medical safety net. We have fleets of ambulances with defibrillators. We have 247 catheterization labs that can put a stent in a blocked artery within 90 minutes.
Right.
We have generic statins and beta blockers. We are basically turning a fatal acute event into a chronic manageable condition. So if you are practicing in a Western clinical setting, you are largely treating the survivors.
But the LMICs don't have that safety net.
Exactly. When you look at the global health landscape, low and middle-income countries are experiencing a rapid, aggressive influx of westernized risk factors.
Like what, specifically?
Well, multinational corporations are flooding these markets with ultra-processed foods, urbanization is creating sedentary lifestyles, and tobacco companies are heavily marketing in areas with loose regulations.
So you'll get all the bad stuff.
All of it. So these populations are getting hit with the disease of affluence hazards, but they do not have the health infrastructure, the cath labs, the widely available secondary medications, the specialized cardiologists to save them when the heart attack actually happens.
It's a collision of new hazards with entirely unprotected populations.
Right.
And the geography of this inequity is staggering. The textbook gives us the death rates per 100,000 people. Let's look at the extremes. The highest mortality by far is in the Russian Federation. For Russian men, the CVD mortality rate is 11,185 per 100,000.
Now compare that to the lowest rates globally. Israel for men sits at just 133 per 100,000, and France for women is at 51 per 100,000.
That is nearly a tenfold difference between a Russian man and an Israeli man.
It's massive.
That cannot just be a sudden genetic variation.
Yeah.
That represents the deep structural inequality we talked about.
It is the perfect illustration of the social determinants of health. The Russian mortality rate isn't just about cholesterol.
No.
It is the historical legacy of the post-Soviet collapse, immense psychosocial stress, massive disparities in alcohol and tobacco consumption, and a health system that struggled to provide consistent primary care and preventative medicine.
Well, the U.S. is sort of in the middle, right?
Right. The United States sits somewhere in the middle, about 250 per 100,000 for men. It underscores that the global blueprint of risk is deeply dependent on the ZIP code, or the country code that you're born into.
So if the macro map shows us that environment and systemic protections dictate survival, we have to ask how we even know what those protections should be. How did we learn to spot the termites? Because up until the mid-20th century, cardiology was entirely reactive.
Totally reactive.
Someone collapsed, and the doctor tried to keep them comfortable. The idea of looking at a perfectly healthy 40-year-old and predicting their future heart attack didn't really exist.
It didn't. And to understand how we got there, we have to rewind to 1948. This is the bedrock of modern public health.
Okay, take us back.
Post-World War II, the United States was facing an epidemic of sudden cardiovascular deaths. President Franklin D. Roosevelt had died of a massive stroke just a few years earlier, and his blood pressure had been dangerously, unthinkably high for years.
Right.
But his doctors essentially just watched it happen because they didn't know what high blood pressure really meant or how to treat it.
It was just considered a normal part of aging, wasn't it? They literally thought the pressure had to go up to force blood through aging arteries.
Exactly. They thought it was a necessary physiological adaptation. So the U.S. Public Health Service decides they need to study this longitudinally. They go to a small, relatively stable town in Massachusetts called Framingham.
The famous Framingham study.
Yes. They recruit an original cohort of 5,209 participants, men and women, mostly aged 30 to 62, who had no outward symptoms of heart disease.
And what did they do with them?
They just watched them. Every 2 years, they brought them in for physical exams, took their blood pressure, drew blood, asked them about their diet, whether they smoked, how much they exercised.
Just gathering massive amounts of data.
Exactly. And then they waited to see who had a heart attack and who didn't, and they correlated the outcomes with the data they'd collected years prior.
And by doing so, they literally invented the vocabulary we're using today. The source notes that in 1961, the Framingham researchers coined the term risk factors.
Right.
Before 1961, your doctor wasn't talking to you about risk factors.
Yeah.
Framingham proved that high blood pressure wasn't normal aging. It was a hazard. It proved smoking caused heart attacks. It proved cholesterol mattered.
It shifted the entire paradigm of medicine from reacting to disease to predicting and preventing it.
Huge shift.
And one of the most vital foundations they and subsequent studies established was the role of family history. We often think of lifestyle first, but your family history is a totally unmodifiable risk factor that sets your baseline vulnerability.
And we need to be precise here, because when a doctor asks, do you have a family history of heart disease? They aren't asking if your 88-year-old grandfather passed away from heart failure.
No, not at all.
The textbook specifically defines premature coronary heart disease, CHD.
Right. Premature CHD is defined clinically as having a male first-degree relative, a father or brother, who had their first coronary event under the age of 45, or a female first-degree relative mother or sister who had an event under the age of 55.
And the compounding effect of that is wild.
Yeah.
I mean, if you have one affected relative meeting that criteria, your risk is 4 times higher than the general population. But if you have 2 affected relatives,
It doesn't just double, it jumps to a 12-fold increase in risk.
12-fold. That's unbelievable. And the statistic in the text that absolutely blew my mind was this. 35% of all early coronary heart disease occurs in just 3.2% of families.
Yeah.
Think about the concentration of that risk. Just over 3% of families carry more than a third of the burden for early heart attacks.
Which naturally brings us to genomics. Because if the risk is clustered that tightly in family trees, the instructions for building that faulty architecture are in the DNA.
Right, the actual blueprint.
We have known about extreme genetic conditions for a while, like familial hypercholesterolemia or FH.
Right, that's the autosomal dominant condition.
Yes, meaning you only need to inherit the defective gene from one parent to have it. The defect is in the LDL cholesterol receptor gene. The liver literally cannot pull bad cholesterol out of the blood.
It's just circulating constantly.
Exactly. In homozygous cases, where a child tragically inherits the defective gene from both parents, their total cholesterol levels can easily exceed 500 mg/dL from childhood.
Good Lord.
We have seen patients with homozygous FH suffer fatal myocardial infarctions by the age of 20.
So here is where I want to push back, or at least play devil's advocate.
Go for it.
We live in an era where I can spit in a tube and get my entire genome mapped for less than $100.
Yeah.
The source material mentions that researchers have identified key single nucleotide polymorphisms, SNPs.
Right.
They specifically call out the 9p21 genomic region, which has a massive statistical association with coronary heart disease. The text gives a p-value of 10 to the negative 8th power.
Which, for those who aren't statisticians, means there is virtually zero chance that the association is a random coincidence. The link is ironclad.
Okay, so if the link is ironclad, why aren't we swabbing the cheek of every 18-year-old at their high school physical, finding out their 9p21 status, and telling them exactly what their cardiovascular destiny is?
It's a brilliant question, and it's one the medical community has wrestled with. But what's fascinating here is we have to make a hard distinction between statistical significance and clinical utility.
Okay, break that down.
Yes, 9p21 is linked to heart disease. But what happens when we take that genetic data and add it to our existing risk models? When you look at how much predictive power that DNA test adds on top of simply asking the patient if they smoke, taking their blood pressure, and checking their cholesterol, the added value is actually very modest.
Wait, really? The genes don't override the lifestyle?
Absolutely not. If you carry the 9p21 variant, but your blood pressure is 115/75, you jog 3 times a week, you don't smoke, and your cholesterol is low, your overall risk of a heart attack is likely still much lower than someone with perfect genetics who smokes 2 packs a day and sits on the couch.
So knowing the gene doesn't actually change what the doctor tells the patient to do. The advice is still, stop smoking, eat your vegetables, take this statin.
Exactly. And in public health, we don't screen for things unless the result of the screening changes our clinical management. Current guidelines do not recommend routine genomic screening for cardiovascular risk because it lacks that clinical utility. Biology is not destiny. It is merely the foundation upon which behavior and environment build.
Biology is the foundation.
I love that.
So if genetics are the concrete slab, let's talk about the structural fault lines that start cracking that slab over time. The metabolic fuel for this slow-burning fire. We are talking about sugar and fat, diabetes, and dyslipidemia.
Let's tackle diabetes first, because its impact on the vascular architecture is devastating. The National Cholesterol Education Program made a monumental classification. They designated diabetes as a CHD risk equivalent.
Meaning what, practically, for the patient?
It means that if a patient walks into your clinic with diabetes, even if they have never had a whisper of chest pain, their statistical risk of having a heart attack is considered equivalent to a patient who has already suffered a previous heart attack but does not have diabetes.
Wow.
You treat the diabetic patient as if they've already had the event.
The numbers back that up aggressively. In men, diabetes doubles the risk of coronary heart disease. But in women, it's a 3 to 7-fold greater risk.
It's astonishing.
The source states that more than 3/4 of people with diabetes will ultimately die not from a diabetic coma, but from cardiovascular complications.
Right.
So let's follow the logical medical reasoning. If high blood sugar is the acid that corrodes the blood vessels, then the obvious solution is to aggressively lower the blood sugar to normal levels. Right? We just medicate them until their sugar is perfect.
That was the exact logical assumption of the entire medical community. And testing that assumption leads us to some of the most fascinating and humbling clinical trial data in modern medicine.
Let's hear it.
Let's look at the early trials first. The UK PDS trial for type 2 diabetes and the DCCT trial for type 1 diabetes.
These are trials testing intensive glycemic control, really pushing the blood sugar down compared to standard looser control.
Yes. And initially, the results regarding cardiovascular events were a bit underwhelming. But years later, during the post-interventional follow-up, long after the strict trial protocols had ended, a clear benefit emerged for the patients who had been tightly controlled early on.
The textbook refers to this as the glycemic legacy effect.
The glycemic legacy effect. It implies that early, intensive control of blood sugar yields long-term cardiovascular benefits. It's as if the endothelial lining of the blood vessels remembers that it was protected during those crucial early years, and that early protection delays the onset of atherosclerosis decades later.
Okay, so early control is brilliant. But here's where it gets wild.
Right.
And honestly, a bit terrifying if you're a prescribing physician.
Yeah.
Doctors looked at the glycemic legacy and thought, great, if lower is better, let's drive everyone's HbA1c, which is the measure of their 3-month average blood sugar, as low as humanly possible. Let's get them down to 6.0 or 6.5%, which is basically a non-diabetic level.
Makes sense on paper.
Right. And that is exactly what the famous ACCORD trial set out to test.
The ACCORD trial is a cornerstone of why we practice evidence-based medicine rather than just physiologically based medicine. They randomized patients to standard therapy versus intensive glucose lowering to hit that target of 6 to 6.5%. And the trial had to be stopped early by the Safety Monitoring Board.
Because it was working too well.
No, because the patients in the intensive therapy group actually had a higher rate of cardiovascular mortality. They were dying faster.
Stop right there. Because if you're listening to this, that should sound entirely backward. Pushing their blood sugar closer to normal killed them. How? What was biologically happening?
We have to look at the nuance of the patient population. The increased risk of death was largely restricted to complex patients, older individuals, who already had prior macrovascular disease, meaning their arteries were already stiff and full of plaque, and patients whose blood sugar remained stubbornly high despite aggressive medications.
So to get their sugar down, the doctors were throwing the kitchen sink at them. Multiple heavy medications, high doses of insulin.
Exactly. And when you aggressively lower blood sugar with heavy pharmacology in a fragile patient, you inevitably cause episodes of severe hypoglycemia, low blood sugar.
Right.
The body perceives low blood sugar as a mortal threat. It panics. It dumps massive amounts of adrenaline and cortisol into the bloodstream to force the liver to release glucose.
And what does adrenaline do? It spikes the heart rate and blood pressure.
Right. In a healthy 30-year-old, a shot of adrenaline is no problem. But in a 68-year-old with a 70% blockage in their left anterior descending artery, that sudden, violent stress demand causes a vulnerable plaque to rupture or triggers a fatal electrical arrhythmia.
Oh, wow.
The medical intervention ended up being more violent and dangerous than the slow-burning disease itself.
That is an incredible aha moment for clinical reasoning.
Yeah.
The Accord trial proves that you can't just treat a number on a lab report. You have to treat the whole patient.
Which is exactly why the American Diabetes Association now advocates for personalized goals. Yes, aim for an A1C of less than 7% for younger, newly diagnosed, uncomplicated diabetics to get that glycemic legacy.
Makes sense.
But we now accept targets of less than 8% or even higher for frail patients with a history of severe hypoglycemia or extensive pre-existing cardiovascular disease.
Okay, so that's the sugar. Let's pivot to the other half of the metabolic fuel, the fat, dyslipidemia, the lipids.
Let's do it.
We all know the prevailing wisdom. LDL-C, low-density lipoprotein, is the villain. It is the cholesterol that actually penetrates the walls of the arteries, gets oxidized, eaten by macrophages, and forms the physical bulk of the plaques.
And unlike the nuanced debate over blood sugar targets, the data on lowering LDL is unequivocally strong. The primary and secondary prevention trials using statins, which are HMG-CoA reductase inhibitors, show incredible, highly reproducible results.
Let's explain how statins actually work, because it's elegant. They don't just act like a sponge soaking up fat in the blood. They go to the liver.
Right. HMG-CoA reductase is the key enzyme the liver uses to manufacture its own cholesterol. Statins block that enzyme.
Okay.
When the liver realizes it isn't making enough cholesterol for its basic cellular needs, it responds by upregulating or increasing the number of LDL receptors on its surface. Those receptors act like molecular vacuums, pulling the bad LDL cholesterol out of the bloodstream to be processed.
And the clinical results of turning on those vacuums are undeniable. We consistently see 25 to 35% reductions in coronary heart disease and cardiovascular incidence.
It's a huge drop.
The text cites a massive meta-analysis of 14 statin trials involving over 90,000 subjects. It showed that for roughly every 40 milligrams per deciliter reduction in LDL, you get an 18% drop in coronary mortality and a 21% drop in all major vascular events.
And importantly, the clinical trials show us that there really isn't a too low when it comes to LDL for cardiovascular risk. Lower is better holds very true.
The TNT study treating to new targets proved that. They took patients and pushed their LDL down to an average of 77 mg/dL using high-dose atorvastatin and compared them to a group at 101 mg/dL on a lower dose.
Right.
And that aggressive lowering yielded an additional 22% reduction in major cardiovascular events.
So we have a highly effective tool. But if statins only reduce events by roughly 30%, that leaves a massive 70% of residual risk.
Yeah, that's a lot of residual risk.
Even with their LDL crushed, people are still having heart attacks. So researchers looked back at the observational epidemiology and noticed something interesting about the other side of the lipid panel. HDL, high-density lipoprotein, the good cholesterol.
The observational data was clear. High levels of HDL were strongly protective, and a low HDL was a major independent risk factor.
Yes.
So the logical leap was made again. If lowering the bad stuff works, let's find a drug that artificially raises the good stuff to eliminate that residual risk.
Which brings us to what we call the HDL paradox.
I love this paradox because it perfectly illustrates the trap of confusing correlation with causation. Let's use an analogy.
Go for it.
Let's say HDL is the police force, and cardiovascular events, heart attacks, are crimes. In towns where you observe very few police low HDL, there is a lot of crime.
A completely sound observational correlation.
Right, so the pharmaceutical researchers say, we need to fix the crime rate. Let's just bus in a bunch of people dressed in police uniforms.
I love this.
They develop drugs like extended-release niacin in the AIM-HIH trial, or CETP inhibitors like delsatrapib, to artificially force the HDL numbers higher on the lab report. They effectively bused in fake police.
And what happened to the crime rate?
Zero clinical benefit. The AIM-HIH trial was actually stopped early for futility. They successfully raised the HDL numbers, but it didn't stop the heart attacks.
Right.
The hazard ratio was 1.02 with a p-value of 0.79, totally statistically insignificant.
This is a profound lesson in pharmacology and public health reasoning. Just because a biomarker naturally correlates with health in a population does not mean that manipulating that biomarker with a drug will magically replicate the health outcome.
The fake police don't stop crimes.
Exactly. The mechanism matters. HDL might simply be a secondary marker of an overall healthy metabolism. Someone who exercises, eats well, and is insulin sensitive naturally has higher HDL. Artificially inflating the protein with niacin doesn't change the underlying metabolic rot.
So what's the takeaway?
The takeaway is focus on the proven causal mechanisms, lower the LDL with statins, and improve the overall metabolic profile with comprehensive lifestyle changes.
Which transitions us beautifully from the metabolic fuel to the physical dynamics of the cardiovascular system. We've talked about sugar and fat. Now let's talk about the physical pressure in the pipes, the pressure cooker, hypertension, and metabolic syndrome.
Let's define metabolic syndrome, or METS, first. It is the crucial bridge between the metabolic fault lines we just discussed and the physical pressure that damages the architecture. Metabolic syndrome isn't a single disease. It is a constellation of cardiometabolic risk factors. It identifies people who are at a significantly heightened risk of developing both type 2 diabetes and clinical CVD.
It's incredibly common. In the U.S., 30 to 40% of adults meet the criteria. The American Heart Association definition requires you to have at least 3 of 5 specific clinical markers.
Let's list those.
If you're looking at a patient's chart, here is the checklist. First, abdominal obesity, which is defined as a waist circumference greater than 35 inches for women or 45 inches for men.
Okay.
Second, low HDL cholesterol. Third, elevated triglycerides, specifically 150 milli-GDL or above. Fourth, elevated blood pressure greater than 130/85. And fifth, impaired fasting glucose of at least 100 mg/dL.
If you have 3 of those 5, your mortality risk doesn't just add up, it multiplies. It's a synergistic effect. And the reason it's so destructive comes down to the endothelium.
Explain the endothelium, because this is the actual physical site where the disease happens.
The endothelium is a single layer of specialized cells that lines the entire inner surface of your blood vessels. Think of it like a pristine, non-stick Teflon coating inside a pipe.
I can picture that.
In a healthy person, it regulates blood flow, prevents clotting, and keeps toxins out of the vessel wall. But when you combine high blood sugar, inflammatory fat cells from abdominal obesity, and high blood pressure, you're essentially rubbing coarse sandpaper over that delicate Teflon coating.
And once the Teflon is scratched, the LDL cholesterol we talked about earlier can get stuck in the scratches, burrow into the wall, and start forming a plaque.
Precisely.
Which brings us to the sandpaper itself, hypertension. The source material is terrifyingly clear on this. For every 20 millimeters of mercury increase in systolic blood pressure, the top number, and every 10 millimeters increase in diastolic, the bottom number, above a baseline of 115/75.
Yeah.
Your risk of death from coronary heart disease or stroke literally doubles.
Doubles. It is a linear, aggressive, and unforgiving slope of risk. 135/85, double the risk. 155/95, quadruple the risk.
It's just wild.
And the clinical presentation of this pressure changes depending on the age of the patient, because the architecture of the blood vessels changes over time.
The textbook outlines a very clear age-based pattern.
Yes. Under the age of 50, the most common form of hypertension is isolated diastolic hypertension.
Okay, what does that look like?
The top number might be, say 125, but the bottom number is high, sitting at 95. The heart is resting, but the peripheral vessels are tightly constricted. However, as we age past 60, decades of wear and tear and early plaque formation cause the large arteries, like the aorta, to stiffen. They lose their youthful elasticity. They can't expand to absorb the shock of the heartbeat.
So the pressure wave just slams through the system.
Exactly. So in patients over 60, isolated systolic hypertension predominates. The bottom number might be normal or even low, but the top number shoots up to 160 or 170.
Okay, so if we know exactly how dangerous this is, and we have dozens of cheap, generic blood pressure medications, ACE inhibitors, calcium channel blockers, diuretics, why does the data show that only about a third of adult patients with hypertension are adequately controlled?
It's a frustrating statistic.
Only a third. If the pills are cheap and the risk is doubled, why are we failing so badly at managing this?
Well, if we connect this to the bigger picture, it points to a complex mix of patient non-compliance. Because high blood pressure is asymptomatic, people don't want to take pills that make them feel fatigued or dizzy when they felt fine beforehand.
That makes sense.
But it also points to the evolving nature of clinical guidelines. Defining the target blood pressure has been a moving target in public health.
Right, let's look at the Joint National Committee guidelines.
Historically, under the JNC7 guidelines, the goal was strictly aggressive. Get everyone below 140/90 and push diabetics even lower, below 130/80. They even created the controversial category of pre-hypertension for people sitting between a 120 and 139 systolic, warning them that a third of them would develop full-blown hypertension within 4 years.
But then JNC8 came out and shifted the goalposts back.
They did. The experts on the JNC8 panel looked deeply at the trial data and realized something crucial about older adults, aged 60 and over. When you use multiple medications to aggressively push an 80-year-old's stiffened arteries below 140 systolic, you cause reduced blood flow to the brain.
Oh, because the pressure's too low to fight gravity.
Exactly. They get dizzy when they stand up, they fall, they break a hip, and a hip fracture in an 80-year-old is often a terminal event.
So the treatment was causing more immediate harm than the theoretical future heart attack.
Precisely. So JNC8 relaxed the target to below 150/90 for that specific older population. It perfectly illustrates how public health definitions of normal are not carved in stone. They constantly shift as we balance the statistical risk of the disease against the real-world, practical risks of the intervention.
Now, we've spent a lot of time talking about biology, enzymes, and medications. But the patient isn't just a passive vessel waiting for statins and beta blockers.
Definitely not.
The patient and the society they live in controls the daily inputs that either reinforce the architecture or accelerate its decay. Let's talk about the behavioral accelerants.
The daily choices: tobacco, diet, and physical activity. Let's start with tobacco, because despite decades of public health campaigning, it remains among the leading preventable causes of death globally, and the damage it does is systemic.
The numbers in the text are brutal. Cigarette smokers are 2 to 4 times more likely to develop coronary heart disease. Their stroke risk is doubled. And their risk for peripheral vascular disease, PAD, which we will define shortly, is more than 10 times higher than non-smokers.
It's astounding.
10 times.
Tobacco smoke is essentially an aerosolized cocktail of endothelial toxins. It drastically accelerates that sandpaper effect we talked about, promotes blood clotting, and lowers the good HDL cholesterol.
It just hits every system.
It does. But the optimistic counterpoint, and this is crucial for clinicians counseling patients, is how fast the human body heals when the exposure stops.
Yes, the recovery timeline is amazing. Within just 1 year of quitting, the excess risk of coronary heart disease is reduced by a massive 50%.
Right.
And within 15 years, the risk is essentially indistinguishable from someone who has never smoked a day in their life.
The body is an incredibly resilient system if you simply stop poisoning it. But here's the public health tragedy. While smoking rates have successfully fallen in places like the U.S., dropping to around 19% by 2010, that victory is being overshadowed by a tidal wave of obesity and physical inactivity.
Yeah, we traded one problem for another.
Since the 1960s, the prevalence of obesity has tripled in men and more than doubled in women.
And the physical activity data is equally dismal. Less than a third of adults meet the nationally recommended guidelines, which aren't even that extreme. 150 minutes of moderate activity, like brisk walking, or 90 minutes of vigorous activity a week.
Recognizing this multi-front war, the American Heart Association promoted a major paradigm shift. Instead of just focusing negatively on disease prevention, they moved toward positive health promotion. They introduced a framework called Life's Simple 7.
Life's Simple 7. If you're listening to this right now, I want you to mentally check your own lifestyle, or think about the typical patient you see in clinic.
It's a good exercise.
The 7 metrics are smoking status, physical activity, BMI, diet, total cholesterol, blood pressure, and fasting glucose. 7 basic metrics. How many people do you think hit the ideal level for all 7 of those?
Well, the epidemiological data says fewer than 1% of adults hit ideal levels for all 7.
Less than 1 in 100. Hold on. If less than 1% of the population can achieve Life's Simple 7, then maybe they aren't so simple.
That's a fair point.
I mean, if a test has a 99% failure rate, the metrics are broken, or the system the patients are living in is broken. It's not just a matter of individual willpower anymore.
I completely agree, and so do most public health experts. Hitting all 7 is incredibly rare because our modern environment is practically engineered to make us fail at them.
How so?
We have built cities that require cars to get anywhere. We subsidize corn and sugar, so ultra-processed food is cheaper than fresh vegetables. We have high-stress jobs that leave people exhausted, relying on convenience food. We are asking individuals to swim upstream against a massive systemic environmental current.
Which perfectly explains why the structural decay is so widespread throughout the body. And that brings us to section 6 of our conceptual outline. Beyond the heart.
Right.
We use the shorthand heart disease. But the cardiovascular system is a single interconnected highway. The exact same pathological process, endothelial dysfunction and atherosclerosis, doesn't just happen in the coronary arteries, it happens everywhere.
Exactly. If the pipes clog in the heart, it's a myocardial infarction. But if the exact same plaque ruptures in the cerebral arteries, it's a stroke.
Makes sense.
The source points out that an estimated 6.8 million Americans have had a stroke, and the vast majority, 87%, are ischemic strokes, physical blockages.
And just like angina chest pain can serve as a warning sign before a full heart attack, the brain gives warning signs too. Transient ischemic attacks, or TIAs.
Right.
These are temporary blockages that cause stroke-like symptoms that resolve quickly. The textbook notes that about 15% of all major strokes are preceded by a TIA. It's a massive red flag.
But another massive risk factor for stroke isn't related to the physical plumbing of the arteries. It's related to the electrical system of the heart. Atrial fibrillation, or AFib.
Explain how an electrical problem in the heart causes a stroke in the brain.
Well, in AFib, the upper chambers of the heart, the atria, stop beating rhythmically, they quiver or fibrillate. Because they aren't squeezing properly, blood is allowed to pool and stagnate in the corners of the atrium, and stagnant blood clots. If one of those clots breaks loose, it gets pumped out of the heart, travels up the carotid artery, and lodges directly in the brain. Having atrial fibrillation increases your risk of stroke fivefold.
Wow. So we have the acute events, heart attacks and strokes, but then we have the slow, grinding epidemic of heart failure. We mentioned earlier that hospitalizations for heart failure doubled over 30 years. If a heart attack is a suddenly blocked pipe, heart failure is just a worn-out pump.
It is the final common pathway for almost all cardiovascular diseases. Whether the heart muscle was killed by a massive infarction or simply exhausted by decades of pumping against untreated hypertension, the muscle becomes weak and stiff.
It just gives up.
It can't pump enough blood to meet the body's needs. Fluid backs up into the lungs and the legs. And despite all our medical advances, the historical Framingham data showed how grim this diagnosis is. Historically, 50% of people diagnosed with heart failure die within 5 years.
And finally, on this interconnected highway, there is the periphery, peripheral arterial disease, or PA. This affects about 8.5 million Americans over the age of 40.
Right.
But here is the critical public health challenge with PAD. It is mostly asymptomatic. Only about 10% of people with PAD actually present with the classic symptom, which is intermittent claudication, severe cramping pain in the calves when walking that goes away with rest.
Most patients feel nothing, but a clinician can easily diagnose it using a simple, non-invasive test called the ankle brachial index, or ABI.
How does that work?
You use a Doppler ultrasound to measure the blood pressure of the ankle, and you divide it by the blood pressure in the arm. In a healthy person, they should be roughly equal, a ratio of 1.0. If the value drops to less than 0.9, it means there is a blockage in the legs. You have PAD.
But here's the question. If the patient's legs don't hurt and they are walking fine, why do we care if their ABI is 0.85?
Because the cardiovascular system is a single connected highway. If the arteries in the legs are that heavily calcified and clogged, you can virtually guarantee that the vital arteries in the heart and the brain are in similarly bad shape.
It's a proxy.
Exactly. PA is a window into the systemic health of the vasculature. The textbook highlights that an ABI less than 0.9 is a powerful, independent risk factor for all-cause mortality, effectively doubling a patient's risk of dying from a cardiovascular event.
Which perfectly segues into our next major concept, measuring the unseen, risk assessment and subclinical disease. If we know the termites are in the walls, how do we find them before the beam breaks? How do we quantify the disease when the patient feels completely fine?
For decades, the gold standard was relying on global risk scores derived from population data. The Framingham study gave us the original 10-year CHD risk score. A doctor plugs in your age, gender, blood pressure, smoking status, and total cholesterol, and the algorithm spits out a percentage probability of you having a heart attack in the next decade. If the number is over 20%, you are categorized as high risk and treated aggressively.
But the textbook notes a major glaring flaw with the original Framingham score. It only predicted hard CHD, meaning only heart attacks and coronary deaths. It completely ignored the risk of strokes, heart failure, and PA. It was only looking at one room of the house.
Which is why modern guidelines, specifically from the American College of Cardiology and the AHA, moved to a more comprehensive tool. The Pooled Cohort Risk Score, also known as the ASCVD Risk Estimator.
That's the one we use now.
Yes. It combines data from multiple massive, diverse cohorts, not just white folks in Massachusetts, and predicts the 10-year risk of both coronary disease and stroke.
But if you're a patient sitting in the office, a risk calculator is still just a statistical guess based on population averages. It's a probability, not a picture. What about actually looking inside the specific patient? We have advanced biomarkers now, like HS, CRP, high sensitivity, C-reactive protein.
Yes, HS-CRP is a blood test that measures systemic inflammation. Atherosclerosis is fundamentally an inflammatory disease. If your HS-CRP is over 3 milligl, it indicates an increased risk of events independent of your cholesterol levels. But again, it's an indirect marker.
So let's talk about direct imaging. We mentioned the ABI for the legs. For the neck, there's CIMT, carotid intima media thickness. You take an ultrasound to the neck and literally measure the thickness of the artery wall.
Though we should note, while CIMT is a great research tool, recent clinical guidelines actually advise against routine CIMT measurement for general risk assessment.
Why? I mean, if you can see the thickness, shouldn't you measure it?
Because of the principle we established earlier with genomics, clinical utility, knowing the exact millimeter thickness of the carotid artery rarely changed the doctor's management plan enough to justify the cost and variability of the test.
But here's where it gets really interesting. There is one test that does have massive predictive power. Coronary artery calcium scoring.
Oh, yes.
You put the patient in a CT scanner, and the machine physically identifies and measures the calcified plaques sitting directly in the coronary arteries. The MESA study, the multi-ethnic study of atherosclerosis, showed that CAC has incredible incremental predictive value. It blows the risk calculators out of the water.
It does. It shows you the physical presence of the disease.
So here's the obvious question. If CAC is the absolute best way to physically see the disease, why not just put every single adult in a CT scanner on their 50th birthday? Make it like a colonoscopy.
This brings us to the eternal tension in public health between screening and surveillance, and between population strategies and high-risk strategies.
Why don't we scan everyone?
First, a CAC scan involves a dose of ionizing radiation. Second, it costs money and requires specialized imaging equipment. But third, and most importantly, we return to the golden rule. Testing must change clinical management to be worthwhile.
Give me a clinical scenario.
Let's say you have a 55-year-old male patient who smokes a pack a day, has type 2 diabetes, and an LDL of 160. According to every guideline on Earth, that patient immediately needs a high-intensity statin, blood pressure control, and aggressive lifestyle intervention.
Right, that's a no-brainer.
Sending him for a CAC scan is a total waste of medical resources. Even if the score comes back 0, you are still going to treat him aggressively because his underlying risk factors are a ticking time bomb. The scan doesn't change your action.
Ah, I see. So who actually gets the scan?
You use the CAC scan as a tiebreaker for the intermediate risk patient.
Okay.
The 50-year-old whose cholesterol is borderline high, who doesn't smoke, and has no family history. You and the patient are on the fence about starting a daily statin medication for the rest of their life.
That makes sense.
If you do the CAC scan and the score is 0, you can safely hold off on the drugs and focus on diet. If the score comes back at 300, you write the prescription that day. You use the subclinical measure only when it dictates the clinical intervention.
That is such a vital distinction for clinical reasoning. All right, so we've assessed the risk, we've used our tiebreakers, we found the termites, now we have to fix the building. The final stage of our blueprint. Upstream engineering.
In public health, we categorize prevention into tiers. Let's define them clearly. Primordial prevention is the most upstream. It's about stopping the risk factors from ever developing in the first place.
Like society-level stuff.
Right. This is societal engineering building cities where people naturally walk instead of drive, ensuring children have access to fresh food so obesity never begins.
Then there is primary prevention. The risk factors are present, but the disease hasn't struck yet. This is giving a statin to someone with high cholesterol to prevent their first heart attack.
And finally, secondary prevention. The building has caught fire. The patient has had a heart attack or a stroke. Secondary prevention is the aggressive, immediate medical treatment designed to keep them alive and prevent a recurrence.
And the clinical shorthand for managing this prevention, especially primary and secondary, is the ABCDEs: aspirin, blood pressure control, cholesterol management, diet, and exercise.
The basics.
Let's touch on the lifestyle interventions, because prescribing a pill is easy, but changing behavior is incredibly hard. For diet, the source emphasizes the TLC diet therapeutic lifestyle changes and Mediterranean eating patterns. The goal is lots of vegetables, whole grains, and limiting total dietary fat to 25 to 35% of daily calories.
But just telling a patient eat less, move more is clinical malpractice at this point. It does not work.
No, it really doesn't.
The ACC and AHA guidelines highlight a sobering reality about weight loss. High-intensity, clinically meaningful weight loss requires highly structured intervention. The guidelines specifically state it requires at least 14 sessions with a trained lifestyle interventionist over a 6-month period.
14 sessions.
Yes. It requires intensive, ongoing behavioral support, not a 5-minute lecture at the end of a checkup.
And what about secondary prevention? When a patient is leaving the hospital 3 days after surviving a myocardial infarction, how do we make sure they don't fall through the
Well, you
cracks?
cannot rely on human memory, not the patients, and not the overworked resident discharging them. The textbook points out that secondary prevention requires systems engineering.
Like checklists.
Yes. We use pre-printed discharge instruction sets. We use automated hard stops in the electronic health records, so a doctor literally cannot discharge a post-MI patient without prescribing aspirin, a beta blocker, and a statin unless they document a specific medical contraindication. We build a system that bypasses human error.
Which brings us to the core tension of this entire deep dive. It's the tension between individual choice scolding a patient to eat broccoli and jog and structural environmental prevention.
Yeah.
Because public health success in cardiovascular disease is rarely dramatic.
It isn't. You don't get a front-page headline for a heart attack that didn't happen today.
Success is invisible. It's measured in incremental population-wide gains. It's measured in heavy tobacco taxation that prevents a teenager from buying their first pack. It's measured in zoning laws that mandate sidewalks so people can walk safely. It's measured in national guidelines that slowly lower the threshold for blood pressure control.
And that leads us to the global governance piece. How do we scale this worldwide? The textbook highlights a major initiative by the World Heart Federation and the World Health Organization, the 25 by 25 target.
The goal was to reduce premature non-communicable disease deaths by 25% by the year 2025. And when you look at how they plan to achieve that, it wasn't through fancy genomic sequencing or personalized medicine. It was through massive, unglamorous structural goals.
Exactly. A 30% relative reduction in average population salt intake, aiming for less than 5 grams a day. A 25% reduction in the prevalence of raised blood pressure. A 30% relative reduction in tobacco smoking. Having the rise in obesity, drastically reducing saturated fat in the food supply, and increasing the widespread availability of generic, essential medicines like statins and diuretics in low-income nations. It is structural engineering on a planetary scale.
It is incredible. We have covered the global burden shifting to LMICs, the foundational legacy of Framingham, the metabolic fault lines of diabetes and the Accord trial mystery, the lipid paradox of HDL, the pressure cooker of isolated systolic hypertension, the interconnected highway of stroke and asymptomatic PV, the exact clinical utility of CAC scoring, and the systems-level engineering of prevention.
It is a massive blueprint.
It is. So I want to leave you, the listener, with a final provocative thought. Something to mull over the next time you are sitting in the clinic or looking at population data. If we know, based on the epidemiological evidence, that 80% of premature cardiovascular disease is theoretically preventable through lifestyle and environment,
Yeah.
at what point does a failure to prevent heart attack cease to be a clinical failure of the specific patient or the doctor and become a fundamental architectural failure of our modern society?
A profound question, and exactly the kind of systems thinking we need. Now, to make sure the foundations of this deep dive are truly solid, we are going to run through 5 rapid single best answer style recall prompts based on the material we just covered. This will help cement the frameworks.
Let's test the blueprints. I will read the prompt, take a second to think of the answer, and then the expert will give you the solution and tell you which section of the textbook to revisit if you missed it. Here we go. Question 1. What is the most common form of hypertension in individuals under age 50? Take a second.
The answer is isolated diastolic hypertension. You can revisit the hypertension section of Chapter 8.1 for more on how this shifts to isolated systolic hypertension as arteries stiffen with age.
Question 2. Which trial demonstrated a glycemic legacy effect for type 1 diabetes, showing long-term benefits of early intensive control? Take a second.
The answer is the DCCT trial. The UK PDS trial showed a similar legacy effect for type 2 diabetes. Both are detailed in the diabetes and metabolic syndrome section.
Question 3. True or false? Recent clinical trials support the use of niacin to raise HDL-C in patients already controlled on statins to reduce residual risk. Take a second.
False. The AIM-HigH trial showed no significant reduction in CVD events, demonstrating the failure of the HDL-raising hypothesis and the danger of relying solely on observational biomarkers. Review the dyslipidemia section.
Question 4. What ankle brachial index, or ABI, value is diagnostic for peripheral arterial disease? Take a second.
An ABI of less than 0.9. Revisit the peripheral arterial disease section for how this asymptomatic marker impacts all-cause mortality.
Question 5. According to the AHA's Life's Simple 7 cardiovascular health metrics, what is the ideal fasting plasma glucose level? Take a second.
Less than 100 milli-GDL. This framework is found in the Measures of Cardiovascular Health section.
Fantastic. Keep questioning the blueprints, look past the visible damage to find the underlying termites, and remember that biology is just the foundation. It's up to us to design a better environment. Here are the details of this episode.
Cardiovascular disease. The silent architecture of risk. Episode description. Cardiovascular disease, CVD, remains the leading cause of death globally. Yet unlike outbreaks or epidemics that command immediate alarm, CVD progresses quietly built over decades through patterns of behavior, biology, and inequality. In this episode of Medlock Holmes, Global Public Health, Holmes turns his attention to the slow-burning architecture of chronic disease.
The global burden and epidemiological transition. Coronary heart disease, stroke, and heart failure. Modifiable risk factors: tobacco, diet, physical inactivity, hypertension, diabetes. Non-modifiable determinants: age, genetics, sex, social gradients, and inequity. Population versus high-risk strategies. Prevention across the life course. Policy-level interventions and structural prevention. Holmes traces how cardiovascular disease shifted from a condition of affluence to a global pandemic affecting low- and middle-income countries disproportionately. This episode examines the tension between individual responsibility and environmental design, between choice and context. Public health success in CVD is rarely dramatic. It is measured in reduced salt intake, tobacco taxation, better primary care, improved lipid control, and incremental gains in survival. The detective story here is long-term. The culprit is cumulative exposure.